cover the waterfront when it comes to therapeutics across the spectrum of disease and different lines of therapy. During the program, be sure to comment below, let us know where you're watching from, and if you haven't done so already, you can complete the pretest at integrasite.com/MUC pretest. So over the course of today's discussion, we're going to really cover this main objective, which is to outline the efficacy and safety findings from key clinical trials of both approved and investigational novel treatments developed for advanced or metastatic urothelial cancer. So I'll first start with a very brief sort of a big picture overview of urothelial cancer treatment. And again, we're really going to focus on evolving changes to this treatment paradigm, including updated ASCO data. We'll talk about first-line chemotherapy, the role of frontline immune therapy, role of maintenance immune therapy, as well as some targeted treatments that have been improved in various lines of therapy. Again, really cover sort of the therapeutic waterfront of this disease. So if you think about first-line chemotherapy, so for the last really 2 decades, chemotherapy has been front and center as first-line treatment for advanced or metastatic urothelial cancer. The good news is that it's relatively highly sensitive to platinum-based therapy. However, patients still had a very poor prognosis, and that therapy was rarely curative. There were rare patients, perhaps with node-only disease, who could have long and durable responses. But for most patients, they either didn't respond or had a short duration of response and then progressed without many viable treatment options. In addition, many patients aren't eligible for cisplatin therapy, mostly due to renal function, but also other things like hearing loss or heart conditions or other comorbidities. And as mentioned, intolerance or disease progression is fairly frequent, has been fairly frequent after first-line chemotherapy. So if you look at, this is a table just of the various targeted treatments that have been developed, say, over the last 5 years. You're all familiar with checkpoint antibodies as listed there, targeting PD-1 or PD-L1. You see the approval dates, now I guess almost 4 years ago. For most of these, the maintenance avelumab being much more recent, of course. You see erdafitinib, an FGFR inhibitor, approved about 2 years ago in the second line. And then ADCs, including enfortumab, and the very recently approved sasatizumab, approved in the third line setting. And we'll be covering those latter rows during the last slides today. More recently, and we can talk about this a little bit, second line's been an evolving landscape. The immune therapy checkpoint inhibitors first developed as monotherapy in the second line. However, 2 of these indications were recently withdrawn, and we can sort of discuss and debate as some of the confirmatory trials for the other ones haven't met their primary endpoints, and there was a recent ODAC on this, and so I think has generated much discussion about, I would say, the evolving role of immune monotherapy in the treatment of bladder cancer, be it upfront or in a refractory setting. So if you look at the first, sort of current first-line treatment for urothelial cancer, this is what it looks like. On the left-hand side, I think that's fairly uncontroversial. Cisplatin-eligible patients get cisplatin-based chemotherapy and avelumab maintenance, as was shown in the avelumab maintenance trial, to improve survival and had the longest median survival reported to date. And that maintenance is in patients with stable disease or better. In the cisplatin-ineligible population, I think it gets a little more messy. You can see this algorithm separates patients into PD-L1 positive and negative. That's not quite as clean as you'd think based on some, I would say, instability of the biomarker, different antibodies that can be used for the biomarker, et cetera. If we just focus on the middle, I think patients who are carboplatin eligible would generally get carboplatin-based therapy and avelumab maintenance, again, with stable disease or better. But then, as noted, the role of immune monotherapy, either for carboplatin-eligible patients, for PD-L1 positive patients, or even for carboplatin-ineligible patients, is, I think, something that we'll debate and discuss. And there have been different data sets, and we'll talk about some of those during the course today of what exactly is the role, and which patients would you use it, and what is the role of the biomarker. That's very much a work in progress. And then if you look at the sort of refractory algorithm, if you will, again, most patients will have received prior platinum-based chemotherapy. Certainly, checkpoint monotherapy is an established treatment option in that setting. For those with FGF alterations, erdafitinib is an established option. And then, as mentioned, more recent additions of enfortumab or sasatizumab. You see the alternative regimens of chemotherapy. I think those are scarcely used anymore. I'm not sure they have much of a role, but that was the standard of care after cisplatin-based chemotherapy for a long time. So I think we'll stop there for a second, and I'll just ask Doctors Galsky and Powell to sort of comment. Maybe first, Matt, if you want to comment, I know you have an opinion about the role of immune monotherapy in the frontline setting. So say patients are not cisplatin ineligible, but carbo eligible. I'd love to hear your opinion on the role of in which patients might you give immune monotherapy.
So I think it still does have a role, although we have to recognize the level 1 evidence with switch maintenance immune checkpoint blockade. We heard updated data at ASCO from one of the data sets with frontline use of immune checkpoint blockade. In the median duration of response in all comers who responded to treatment was over 30 months, and it was not reached in patients with tumors harboring high PD-L1 expression. And so when these responses occur, of course, that can be quite durable. And a patient who has maybe indolently progressive disease, maybe lymph node only metastatic disease, who's a little bit more on the frail side and says, I don't want chemotherapy, I have no qualms about offering them single agent immune checkpoint blockade based on the data.
So this would be a PD-L1 positive patient.
That's correct.
Yeah, and maybe who has non-liver mets, non-bone mets would be the kind of, more indolent disease that you would generally think of might be the kind. And what percent of your practice do you think that represents?
Yeah, that's hard to say. Maybe 10, 15%.
So still a fair minority of patients. Tom, what do you think about that topic? In whom do you give immune monotherapy up front, or do you at all?
So I think I'm actually very much aligned with what Matt has said. My concern is that when this journey started 4 or 5 years ago, when these drugs were approved, we were probably treating a third of the patients with upfront immune therapy. And what became apparent very quickly was we were losing a lot of these patients. And I think that what's happened subsequent to that is an alternative approach with chemotherapy followed by switch maintenance avelumab has taken away some of the uncertainty in that now we can get in control with chemotherapy and maintain that control. But I agree that there is still a role for monotherapy. I don't know about the biomarker. I'm not sure the 223 PD-L1 biomarker is performing particularly well in the randomized trials. I think Matt knows a lot about the 142 biomarker with atezolizumab that does seem to be performing a bit better, although it's sort of, I think it will end up being an exploratory type analysis, which is always going to be difficult. But the story, I think, for me is that this approach has not been revolutionary. It's been a step in the right direction. We've shown that we can generate long-term durable responses in bladder cancer, but we don't know who those patients are, and we lose too many along the way to say this has been a revolutionary step. I think it's the first chapter, I hope, of a book. There's a study with ipilimumab and nivolumab around the corner. I hope that's going to be positive in the PD-L1 positive population, getting control of more patients because of the combination therapy. We saw in the Danube trial, durvalumab and tremelimumab performing a bit better than durvalumab alone. But I don't think this is, for me, this isn't as exciting for frontline as I wanted it to be. And I think we're with now the switch maintenance approach until we find something substantially better.
And Tom, do you think the same patients who might be durable responders to, say, pembro monotherapy up front are going to be the same patients who will do really well with that switch maintenance approach, but they just happen to get chemo up front and immune therapy later?
Yeah, so it's worthwhile looking at that. So if you look at the the carbo-gem patients who were cisplatin ineligible biomarker high in the 361 trial, their CR rate was 18%. Had you flipped that round the other way and got 18% CR with immune therapy, everyone would be singing from the rooftops. The reality is that unfortunately the 361 biomarker is picking for the winners in both. But unfortunately the biomarker also, we lose some patients initially along the way. So I think the problem with the biomarker is it doesn't pick those patients that exclusively benefit from immune therapy. It picks the chemotherapy winners as well. And dare I say it, Brian, in the original studies with atezolizumab, when we saw those terrific results with PD-L1, we then did the 211 trial, the randomized trial, and we found actually we were picking the chemotherapy winners as well. So this issue about predictive and prognostic effects is really important. And for what it's worth, it looks like the IC component is more prognostic. And in my feeling, the TC component is more predictive of PD-L1. And that's why we should stop calling it PD-L1. We should start talking about PD-L1 alpha, beta, gamma, delta, depending on which method we're using, because you get completely different results.
Yeah, agreed. Matt, any follow-up or comment on what Tom said?
No, I just completely echo that. We're testing different things. It's ridiculous that we call it the same thing.
So it sounds like we agreed there's probably some small role for checkpoint inhibition monotherapy in the frontline setting. We're not exactly sure how to pick patients.
The important thing, I think, is that from my perspective, is I don't want the FDA to withdraw these labels. I think the trials weren't positive, and the confirmatory trials are not positive or not yet positive. But I think it would be a retrograde step to take those away. But then I know people say, well, Tom, you would say that. I have mixed feelings about it, because I am a bit of a statistical purist, and I think the FDA is a really good organization for approving these drugs quickly, because it allowed us to develop these drugs. But I do think in the right hands, we can pick a group of patients who otherwise wouldn't necessarily get long-term durable remissions.
Yeah.
Particularly those who are not eligible for any platinum-based therapy.
Right. Yeah, I think that's an easier choice. It's those carbo-eligible patients, which I think most patients are, but don't want chemotherapy and their biomarkers inconsistent. I think that's the population I think that I personally struggle with. So let's move on. I think we're going to move on and talk about adjuvant therapy, and I'm going to turn it over to Dr. Powles to take us through the next set of slides.
Great. So, Matt, I'm talking about one of your studies. They allocated that to me, which I specifically asked for. So this is the randomized phase 3 trial. This is in high-risk patients who have had a cystectomy for high-risk urothelial cancer. A proportion of these patients previously have had neoadjuvant chemotherapy as well. It's an unselected population. The biomarker positive population was also an endpoint of this study, and this is statistically significant for progression-free survival. It's a trial against placebo and not best supportive care, and I think this is relevant. If we move to the next slide, this is the PD-L1 positive population, and again, is disease-free survival, and the hazard ratio comes down further. This is the TC biomarker, and this is one of the slides, which is why I think TC might be more important than IC. There's other data to support that statement as well from the Javelin 100 exploratory biomarker trial. And one of the questions which we need to discuss really is whether or not these data are practice changing as it stands from a global perspective. If we move to the next slide, when one looks at the safety data associated with this, actually it's very much in line with what you would expect from nivolumab. We're having a relatively modest proportion of patients discontinuing, modest steroid use. And so essentially it's a well-tolerated regime, but it does last for a year, and adjuvant immune therapy is associated in a small group of patients with long-term life-changing side effects. So receiving adjuvant therapy without a clear survival signal, in the knowledge that there is a risk to run, and on top of that, and importantly, we know 50% of patients won't need any adjuvant therapy. They're going to be cured by neoadjuvant chemotherapy and surgery. So inherently, we're over-treating 50% of patients and potentially putting them in harm's way because of the long-term durable side effects. If we move to the next slide. The other piece that's concerning me is the only survival signal that we do currently have is the survival signal from atezolizumab. Now, clearly it's a PD-L1 versus a PD-1 inhibitor, and I'm not sure we'll cover the discussion about whether these drugs have more similarities or differences in urothelial cancer. My feeling is there are more similarities than differences. This was a negative trial for PFS and for OS. Now, clearly, when one extrapolates from that, I think there is a desire to see the nivolumab OS signal in 2.7 before we jump into treating an unselected group of patients. If we move to the next slide, this is a slightly complicated slide. Essentially, The left hand is disease-free survival. The right hand is overall survival. This looks at ctDNA, circulating tumor DNA, at baseline after the cystectomy, prior to the randomization of receiving atezolizumab or placebo, or best supportive care. And the dark blue and the dark red, the two bottom curves, are ctDNA positive. And you can see here that not only, and the peach and the light blue are ctDNA negative. And you can see here that the dark blue and the dark red, both the positive patients having more progression and dying more quickly. But importantly, those atezolizumab treated patients seem to be doing better in this exploratory analysis. And what this is telling us is we may be able to select those patients at high risk with minimal residual disease to treat with atezolizumab or indeed immune checkpoint inhibitors if this data was repeated in 274. There are advantages of circulating biomarkers over tissue-based biomarkers. Remember, if it's a tissue-based biomarker, you've done the cystectomy, so some of those patients inherently are going to be cured, irrespective of how aggressive the tumor is in the pot. Whereas, of course, ctDNA allows you to identify minimal residual disease. And there's some work coming out on Monday in a good journal, which is going to describe this data, and it's going to link this ctDNA positivity with a whole plethora of immune biomarkers, really underpinning the biology of ctDNA in urothelial cancer, which we're excited about. Next slide, please. Brian, Matt, I guess for me, I've said a couple of provocative things on purpose because I'm hoping you're going to might disagree with me a little bit. What's your take on what I've said so far?
So I think that the decision about whether or not disease-free survival is a clinically relevant endpoint isn't only our decision to make. Metastatic recurrence of urothelial cancer is devastating from an emotional and oftentimes a physical standpoint. And I think our patients and their families are smart enough to be able to weigh these treatment decisions in terms of the risk versus benefit of reducing recurrence by 30 to 50%, and against the risk for some of the immune-related adverse events, and make a shared decision about treatment. So I don't know that that's completely our decision in terms of the clinical relevance of this endpoint. The second thing that I'd say is that I think the ctDNA data are no question intriguing and important, but the ctDNA negative group has a 30% chance of metastatic recurrence. And so using those as tools to decide who needs treatment versus not, I would love to see, but it needs to be tested.
So Matt, at present, you would offer adjuvant nivolumab to an unselected population or just PD-L1 positive?
I discussed the data to an unselected patient population, and certainly discussed that the effect seems to be increased in patients with PD-1 high expressing tumors.
Sure.
I think the European perspective is slightly different from that, and I think that we probably are going to. I'm not involved in the EMA, but it's not clear to me as it currently stands that I don't think it would. It's going to be quite a close run thing. I think they'll be asked. I think the EMA will ask for. I don't know what's going to happen, of course, but I suspect they'll ask for an OS cut of some description to have a look. Because Matt, I guess one of the questions for you, which I don't know what you think about this. I don't know what you think about many things. But how do you feel about a negative atezolizumab trial? You're going to say to your patients, actually, it's just nivolumab's a better drug here. It's as simple as that.
Well, you've heard my explanation of the discrepancies between the studies, and we probably don't have time to go through that fully, but I think that there are differences in the trial design that can account for those differences. And I think you yourself agree with the hypothesis that immune checkpoint blockade improves outcomes in the adjuvant setting with atezolizumab. You just presented the ctDNA data that shows that. And so your argument is not that these drugs don't work in the adjuvant setting, is that it's the patients weren't selected appropriately, and perhaps
you become my lawyer, Matt. You become my lawyer.
and so perhaps the patient populations were just different enough to account for that.
Is it a PD-1 versus PD-L1? I mean, in kidney cancer, that's pretty clear that PD-L1 isn't as active, but I don't know that the data is as compelling in use.
I don't think it is. And again, if you believe the ctDNA data, then you believe that adjuvant atezo works. It's just that you selected the patients wrong.
Yep.
And we've got as many PD-L1 positive trials as we have PD-1 positive trials in urothelial cancer, and as many the other way around. You know, I think it's a fairly balanced now. Who knows the detail, and cross-trial comparison is quite difficult. Matt, you are over-treating 50% of patients if it was the ITT population, and you don't have OS, you are going to put some of those patients in harm's way. How strongly do you feel about, I mean, would you be saying to your patients, really, if you were PD-L1 negative, and we haven't seen that data, would you be really saying to those patients, I think I think this is the right thing to do?
I think that the PD-L1 negative question is complicated, admittedly. But I think that the nature of adjuvant treatment is that we overtreat patients given what is at stake. You do that when you give someone neoadjuvant chemotherapy every day. And so that's where what's at stake in terms of the outcomes becomes important. And we're trying to cure people here. And ultimately, we'll know that when we have survival data. But in the meantime, there are patients who are in our clinics today who want the answer.
Matt, what are your prospects on the neoadjuvant trials? You're going to talk a bit about some neoadjuvant radiotherapy, and I think you're really interesting data around trying to spare cystectomy altogether. There are some neoadjuvant trials that are running. Do you think they're going to be more positive than the adjuvant trials?
I think the precedent in terms of neoadjuvant immune checkpoint blockade versus adjuvant, although it's a very small experience in other solid tumors, would suggest that the neoadjuvant approach might have some benefits. I think how the combination chemo immune checkpoint blockade story plays out in the neoadjuvant setting versus the metastatic setting is the wild card here. And hopefully it's a different story in the neoadjuvant setting.
So great discussion, guys. I think in the interest of time, we're going to move on to the next set of slides. And I think, Tom, you're still on for talking about 052 follow-up.
Yeah, I'm going to go fast. So we have talked, this is Keynote 52. This is the frontline data which generated the accelerated approval for pembrolizumab. You remember there was the 210 trial, which generated the accelerated approval for atezolizumab, single-arm study. And this is the longer-term outcome data. We just saw the 5-year data, indeed, at ASCO, which Peter O'Donnell broadcast. And Peter and I have many debates on this, which I'm convinced I win them all, but apparently that's not the case. And this is the updated data. I think Matt described it at the beginning well. I think there is no doubt that if you could pick those winners, there are some patients who do really well. And we feel that they're the lymph node positive patients. They're the patients with relatively slow growing disease. But we do lose some patients along the way. Let's move to the next slide. This is an important slide because this is where the two current labels lie. So you'll be aware that atezolizumab with the 142 biomarker and pembrolizumab with the 22C3 biomarker. And this is the subset of 361 and 130 in the carboplatin treated population. And you can see from here, as I described previously, this is an example where it looks like the atezolizumab data looks a bit more compelling. Now, I don't think that's because atezolizumab is a better drug. I think it's because the biomarker is performing better here. But you might come back to me and say, why is the biomarker performing well first line when 211 it didn't perform second line? And I haven't got a good explanation for that. And what I can tell you is that the pembrolizumab and atezolizumab, in terms of their landmark analysis, perform quite similarly. The striking feature here is how well the chemotherapy does in the 361 pembrolizumab study. Mm-hmm. And as I said before, it looks like that 22C3 biomarker is picking some of the winners. Remember, only 25% of patients are positive with the 142 biomarker, whereas it's more like 50-55 with the 22C3 biomarker for pembrolizumab. Let's move to the next slide. And this is the Javelin study looking at the ITT population. So this is patients with metastatic urothelial cancers whose cancers have not progressed on chemotherapy, who then get maintenance of avelumab or best supportive care. This has a hazard ratio of 0.69. It's a bit more marked in the biomarker positive population, but actually I don't think the biomarkers work particularly well here because it seems to also be effective in the biomarker negative cohort. And so let's move to the next slide. And I guess this is an update of the Javelin. There have been many different updates of this, and this is looking at the different duration of chemotherapy, and it's trying to get some impression of whether or not, you know, it works well if you stop after 4 or you stop after 6. My position on this is quite simple as it currently stands. We should aim to give 6 cycles of chemotherapy where possible. I totally understand not everyone gets there, but if they can get to 6, we should treat to 6. I don't feel that we should be stopping early to switch to avelumab without more supportive data, but if it is 4 cycles rather than 6, it's equally effective under those circumstances. But what we don't know is if you need to keep going with the chemotherapy, and there's going to be a European trial comparing 3 and 6 cycles of chemotherapy followed by maintenance of avelumab. Let's move to the next slide.
So I think we're going to pause here and discuss before we go over to Matt on second and third line. I think for just the role of maintenance therapy. I mean, I think it's clearly a standard as we outlined in the algorithms. Is aside from progressors, is there anybody, Tom, you don't give maintenance therapy to? You know, or what are you using as markers during maintenance therapy to know how long to continue?
The questions are good, Brian. I think that most people, you're better off giving the immune therapy as I can see it, because not everyone's going to get the opportunity if you wait for bladder cancer to progress. The median time to progression for even the CR patients, those that have had a complete response, is only 4 months. So chemotherapy is a transient response in urothelial cancer. It's different from other tumor types. Mm-hmm. And so if the opportunity to give the immune therapy is in front of you, it makes sense doing that. There are patients who desperately don't want to start because they've had a difficult time with chemotherapy. Under those circumstances, I probably would stop the chemotherapy 1 or 2 cycles early. If it looks like you're unable to get the chemotherapy in, you're probably better off stopping a little bit early and sequencing onto the immune therapy rather than pushing in the last 2 cycles. Clearly, patients with ongoing active autoimmune diseases are not candidates for immune therapy. The remainder, I'd put in that category. Clearly, it excludes those patients who have progressed on chemotherapy, and treating patients who progress on chemotherapy is pretty challenging.
Yeah. And Matt, any other comment on maintenance therapy?
No, I recommend maintenance therapy regardless of the response to frontline chemotherapy, regardless of PD-L1 status. I have had patients who want a break and decline maintenance therapy, but aside from that, I recommend it based on the level 1 evidence.
And one last question before we go into the other slides. Tom, I mean, in Javelin, the maintenance therapy was 1 year. Is that correct?
No, you can keep going. So in the trial, it was go until progression.
It was until progression. Okay, yeah. Never mind then. Okay, I think we'll turn it over to Matt now. He's going to talk about some of the data in the refractory setting.
So 2 new classes of drugs that have been introduced to our treatment armamentarium for urothelial cancer just in the past few years. One are group of drugs directed against mutant FGFR3, and then the others are a group of antibody drug conjugates. So we'll talk about the FGFR inhibitors first. Mutations in FGFR3 are found in about 15 to 25% of patients with muscle-invasive bladder cancer, initially described over 20 years ago, and it took a while for these drugs to be, for that finding to be translated into the clinic. But now we have a group of potent and selective inhibitors of FGFR3, which have shown activity in the clinic. Only one approved by the FDA thus far, and that's erdafitinib, and that was based on a large single-arm study in enrolling patients with metastatic urothelial cancer harboring FGFR3 alterations or fusions who had progressed to prior platinum-based chemotherapy. And you can see the waterfall plot here, an objective response rate of 40%, responses regardless of the presence of fusions or mutations, and responses in terms of durations can be durable with these drugs, and so really have been an important addition to our armamentarium. Next slide. And here's the median OS and median PFS, of course, difficult to interpret in the context of a single-arm study, but you can see from the PFS curves that some patients do enjoy a durable response to these therapies. Next slide. So the other class of drugs that have been introduced are antibody drug conjugates, and we have 2 ADCs that have been approved by the US FDA for the treatment of urothelial cancer. We have enfortumab vedotin, which includes an antibody directed against Nectin-4, which is pretty ubiquitously expressed on urothelial cancers, and that has the cytotoxic payload MMAE. And that initial approval was based on the EV201 study. The initial approval was based on a single-arm study which enrolled patients that had received prior platinum-based chemotherapy and immune checkpoint blockade in enfortumab vedotin, really demonstrating significant activity in that patient population. Enfortumab vedotin has then been studied in additional patient populations as well, and we were speaking a little bit about patients who receive frontline immune checkpoint blockade, and really for patients who receive frontline immune checkpoint blockade for metastatic urothelial cancer, there's really been no defined standard subsequent lines of therapy. And so the prior slide showed results for a single-arm study where patients received enfortumab vedotin as their second-line therapy, and a response rate of about 55% in that patient population. So that wasn't compared to carboplatin-based chemotherapy. That said, compared to what we expect historically with carboplatin-based chemotherapy, response rate's pretty respectable. Ultimately, enfortumab vedotin was compared with standard chemotherapy in a randomized phase 3 study, which enrolled patients who had received prior platinum-based chemotherapy, and patients were randomized to enfortumab vedotin versus chemotherapy, which could have included a taxane or vinflunine. This study with an overall survival endpoint, and you can see here enfortumab vedotin associated with an improvement in overall survival with a hazard ratio of 0.7, really solidifying the results that we saw in the phase 2 setting, and leading to approval by regulatory agencies in various parts of the world. Next slide. There is a somewhat unique side effect profile with enfortumab vedotin. There are side effects that are traditional cytotoxic chemotherapy-like side effects as a result of the cytotoxic payload, but there are a few unique side effects as well. A rash, as can be seen here, occurs in a subset of patients, and the rash can be very mild and bothersome to a very severe rash necessitating stopping treatment. Peripheral neuropathy is a cumulative dose-related side effect with enfortumab, certainly a relevant side effect to our patient population who have often received platinum-based chemotherapy before, and so that's something that does become more relevant as patients continue treatment longer. And then hyperglycemia occurs in patients treated with enfortumab vedotin, and that requires very careful monitoring of glucose levels. There are a few safety considerations in that regard. One is that there is a labeled indication to hold enfortumab vedotin for glucose levels greater than 250, and there is a cap in the dosing of enfortumab. So it's 1.25 mg per kg, but there is a cap of the dose at 125 milligrams because of the potential risk for hyperglycemia and lactic acidosis that was seen in the earlier phase drug development. Next slide. The other antibody drug conjugate that's been introduced is Sasatizumab Gogotican. This is an anti-TROP2 antibody with SN38 as the cytotoxic payload. The development scheme, the clinical development scheme for Sasatizumab, very similar to enfortumab vedotin in terms of the clinical trials that have been done. So we have a large single-arm phase 2 study enrolling patients who had received prior platinum-based chemotherapy, and including patients who have received prior immune checkpoint blockade as well. And you can see here the objective response rate of 31% in this cohort. And similar to enfortumab vedotin, response durations here seem a little bit in between what we've seen with traditional cytotoxic chemotherapy and what we see with immune checkpoint blockade, in that the responses can be prolonged with these agents and oftentimes can continue even when the drugs are held for a period of time. Next slide. And here's the waterfall plot with sasatizumab in that patient population. And you can see here that in addition to patients meeting that sort of arbitrary criteria for objective response, there's a good proportion of patients who have some shrinkage of tumor. Next slide. The safety profile of Sasatizumab Gogotican different than enfortumab vedotin, very much more related to the topoisomerase inhibitor payload. And so you see cytopenias, you do see some febrile neutropenia with this drug, and you do see diarrhea. And so different side effect profile, different payload, different antigen, and potentially non-cross resistant drugs. And of course, with these now in clinical use, we'll get a better sense for that. Next slide.
So I think we're gonna pause there. I think that's the end of this sort of second, third line discussion. And maybe I'll ask, and Matt, I'll start with you. Let's take a typical patient who's gotten a platinum doublet and a maintenance availumab, but then progressed and is coming to you for treatment. How do you decide which of those three options, erdafitinib, enfortumab, and sasatuzumab, you're going to give a patient? Obviously, erdafitinib only in FGF mutants, but let's assume the patient is FGF mutant. How do you decide on which to start or how to sequence? Is there a strategy there?
So if there is an FGFR alteration, then typically I'll start with erdafitinib. In the absence of that, I'll start with enfortumab, based on the level of evidence that we have available right now. The only times when I wouldn't do that would be, for instance, a patient who has severe neuropathy from frontline platinum-based chemotherapy.
Sure. And Tom, what do you think? How do you approach those patients?
Yeah, I mean, I think I probably would go for enfortumab vedotin, even in those individuals with FGF alterations, until we've seen the randomized data for erdafitinib. I think the enfortumab vedotin data is more compelling as it currently stands with level 1A evidence. I certainly, I certainly feel that enfortumab vedotin with response rates of 40% and that survival signal is probably the more compelling data, even on single arm, than sasatuzumab as it currently stands, with sasatuzumab's response rates being about 10% lower. And I know that's cross-trial comparisons and all the bits and pieces that go with that. But if you have level 1A evidence for one drug and the phase 2 it appeared to perform a bit better, it's hard to be picking sasatuzumab currently over enfortumab vedotin. I agree with what Matthew has said. I think patients with severe peripheral neuropathy, I mean, grade 1 peripheral neuropathy, I think is okay. But more severe than that, you need to be a little bit careful, in my opinion, and that might not be the right choice. And then, of course, there are these trials, the randomized trials for both erdafitinib and sasatuzumab in this setting, which are both currently still enrolling really important studies, which will help us make the decision. We don't need too many choices in this space, to be honest. What we really need is a positive frontline randomized trial. And for me, the two outstanding trials are the ones I mentioned already, the ipilimumab and nivolumab study in the biomarker positive population, which I'm really excited about. I also think the EV302 trial of enfortumab vedotin plus pembrolizumab versus chemotherapy, I think has the highest chance of replacing chemotherapy. Remember, the frontline response rate was 74%, which does seem high.
So we're going to move on. We're running out of time here, just about 5 minutes left. So if we go to the next slide, Matt, I'm going to ask you to go into some of this sort of interesting bladder sparing data, the first slide of which was your study.
So at ASCO, 3 studies presented in patients with muscle-invasive bladder cancer seeking to explore novel approaches to bladder sparing. The first that I'm going to cover is a study that the first study that I'm going to cover is one that we did, which enrolled patients with muscle-invasive clinically localized bladder cancer. Patients were treated with 4 cycles of gemcitabine cisplatin plus nivolumab And if they achieved a complete clinical response, they were offered the opportunity to receive an additional 4 months of nivolumab and then observation without having their bladder removed. If they didn't have a complete clinical response, then cystectomy was recommended. We had a median follow-up of about 1 year, so the follow-up is relatively short so far, but you can see the data at 1 year. And I think what you can see from this data that becomes quite apparent is that clinical complete response is stringently defined as probably a prognostic biomarker. That's actually what we want it to be. We want it to be a prognostic biomarker to make treatment decisions in this setting. And you can see that if you've achieved a complete clinical response, then the chance of having an intact bladder without evidence of recurrence at 1 year was 81%. And so early data, this is a different approach than the approach combining chemotherapy or immunotherapy with radiation, but an approach that capitalizes on someone's response to treatment in terms of trying to determine what to do moving forward. We talk a lot about predictive biomarkers. Probably nothing more predictive about a patient's cancer and the behavior of that cancer than how it responded to the treatment that you actually already gave it, rather than trying to predict the future. And so that's the information that we're trying to capitalize on. Next slide. So the next study was a very interesting study that sought to combine 2 immune checkpoint inhibitors, durvalumab and tremelimumab, PD-L1 blockade and CTLA-4 blockade with radiation. So a chemotherapy-free immunotherapy concurrent radiation study for patients with clinically localized muscle-invasive bladder cancer. A clinical complete response rate of 81%, and the bladder intact survival was presented at ASCO. And so far, again, relatively short follow-up with these studies, but reasonable bladder intact disease-free survival that we're seeing. So, and then the third study that was presented was gemcitabine twice weekly plus pembrolizumab plus radiation. So we're seeing these approaches emerge, bladder sparing, integrating immune checkpoint inhibitors. There are a few randomized phase 3 studies testing the immunotherapy, radiation, chemotherapy approach. And I think these studies have the potential to increase the use of bladder sparing strategies in muscle invasive bladder cancer.
So thanks. We just have 2 minutes left. I'm going to ask you each in the next 30 seconds. Tom, we'll start with you. Anything else from ASCO 21 that you think impacts bladder cancer? Obviously, we've talked about a lot, but anything else sort of, in a poster or something you saw you thought was exciting?
Yeah, there was some HER2 ADC work that came out of China that I thought was intriguing, with high response rates in combination with immune checkpoint inhibition. But I do think that the data that Matt just presented, Arjun and Matt and the Spanish group presented at ASCO, looking at bladder sparing surgery, bladder sparing approaches, radiation therapy in that environment. I think this has got a really good chance of changing the way we think about urothelial cancer in the future. And we suddenly have got a huge amount of emotional investment in this bladder sparing approach, which I think is really important. I don't think all the patients need to have a cystectomy with T2 disease, and we really need to pursue this.
Matt, anything to add to that?
I agree with that. There were a few comments at ASCO about the fact that bladder sparing with concurrent chemoradiation has been around a long time, and there's solid data for it. So this isn't a new approach, and sometimes it takes a novel agent to be included to be the tipping point. And I think we're seeing some of that, and I think that's okay if ultimately it leads to this approach being used more commonly.
So thanks. So just to wrap up, we're exactly out of time. I won't read the summary slide to you, but finally, it's an exciting time in bladder cancer. We now have many mechanisms, many different drugs. We're talking about sequencing, which is something we never really talked about before in this disease, unfortunately. And I'll just end by saying hopefully there'll be more exciting data to come at ESMO this year and beyond. We'll be happy to sort of come back and do another one of these. Hopefully a lot of more exciting data to come out. And I'd just like to thank Dr. Galsky and Powles for joining me, and thank all of you for your attention.
Thank you.
Thank you, everybody.